Hello, friends. So today I'll be talking on this topic, gas flow dynamics, which guides the ventilation strategies. So this talk I had to give in indoor conference in November 2022. So I wish to acknowledge my colleague, Dr. Amrita, who helped me prepare this content. So in this particular topic, I'm sure most of the listeners would be aware of the pressure, flow, and the volumes and the time that determines the ventilation strategies. But throughout this narrative, since the topic is only gas flow dynamics, so I'll be focusing only on the flow principles that govern the ventilation strategies. So I wouldn't be touching base on the pressure or the time constant or other aspects, although there may be some mention about these independent variables. So the topics that I would cover, because this is a dry topic, so I should warn the listeners that you need to pay little attention, and these are extremely important for our daily working on the ventilators. So the topics that I would cover is the physics. It's extremely important we understand the basic physics before even we dwell upon other nuances of flow dynamics. Then it is important to understand what are the determinants, because our whole intent is to ventilate a patient. So understanding this flow dynamics is with an intent that we save a life by providing good oxygen and eliminating excess carbon dioxide. So that remains the core principle. So it is important that one understands the determinants of this ventilation. So what determines adequate oxygenation and what determines carbon dioxide removal. And with regards to flow dynamics, so we would dwell upon flow time, which is a scalar mode, and how various pathologies manifest with regards to this, and the flow volume. We look into flow volume, so and various pathologies that can be identified with the flow volume. Then very briefly, we look into asynchronies that can be identified in these flow dynamics. So be it flow time or flow volume, what are the different asynchronies? The reason we have to talk about asynchronous is even the latest advances that is happening in ventilation are dwelling upon rectifying or mitigating the asynchronies, because the artificial intelligence which is being incorporated into ventilator primarily are identifying significant asynchronies that prevail between the machine and the patient. And correcting this will enormously improve the ventilation. So with that in mind, asynchronous become important for us to recognize. And all this physics and all this flow, is there a bearing on patient's outcome? And what is it that these flow and flow dynamics would have with regards to bearing on the lung stress? So we'll talk very briefly on the impact of these flow dynamics on the lung, and we call it as lung stress. And what is the way that we could monitor lung stress? Is there any practical way to monitor lung stress? And then we'll talk to take home message. So first we'll touch about physics. So this is extremely important to understand the basics of ventilation. When we talk about any physics, we look at the airway pressure. So if you look at this as an airway, and this is an alveoli, which is the functional unit of the lung. So the airway pressure is determined by this components, and this is very, very vital for any one's understanding of the ventilation. So your flow in the airway is determined by flow and the resistance that the airways confer, along with the volume and compliance of this alveoli plus PEEP. PEEP is the pressure that keeps the alveoli open. So summarily, if you have to look into an equation, the airway pressure is flow into resistance, which predominantly determines the passage of air into these airways, plus volume divided by compliance, which will determine how effectively alveoli is accommodating the flow of air. And with PEEP, PEEP is the baseline pressure that is keeping the alveoli open. So this is something which we need to understand in a fundamental way, and this remains very sort of integral to understanding our flow dynamics. So flow into resistance plus volume divided by compliance plus PEEP. So this is something which we need to understand. So summarily putting, the airway pressure is dependent factor. And as you know, it is dependent on flow and it is dependent. See, resistance, we don't have control. Resistance of the airway is, primordially determined by the underlying pathology. And flow is something that one can set. And volume is something that we can set. And the compliance of lung is something that we cannot have any ability, because that depends on the innate nature of the lung. And PEEP is something that a baseline PEEP that all of us have, which will keep the alveoli open. So the airway pressure pretty much depends on the flow that we set and the volume that we set. And the resistance is something that is determined by the nature of the lung, and the compliance is something that is determined by the underlying pathology. And baseline PEEP is what is existent. So the two parameters that we can set is the flow and the volume. So this is just a schematic representation. Our whole principle of ventilation is to get the oxygen in and get the carbon dioxide out. So this is what we deal with. And when we deal with ventilation, there are mainly two pathologies that we would be dealing. One is the compliance, and the predominant factors that would be determined is your alveolar sort of a factors. And then the second important pathology that we would be dealing with the resistance factors or the airway factors, or COPD or asthma or so on and so forth, where you have issues with carbon dioxide and the means that we need to adopt to get this carbon dioxide out. So now we'll talk about what are the main determinants to improve the oxygenation in an individual. So if you have to obviously optimize oxygen, so we have to improve the oxygen delivery, which is by increasing the FiO2. The second most important aspect which we would dwell with, increasing the mean alveolar pressure. So this is something which every listener should pay attention, because the means that we adopt to improve the oxygen, FiO2 is a simple thing, but we need to understand what are the means that we can adopt to increase the mean alveolar pressure. And the PEEP, because the intrinsic PEEP, what patient has may not be good enough. So we need to provide extrinsic PEEP to reopen alveoli and reduce the shunt fraction. So these are three important components that are utilized to improve the oxygen. And what are the components to remove the carbon dioxide? Because that is the second important pathology that we deal with. So to get the carbon dioxide out, we have to increase the ventilation. This increase in the ventilation can happen in two ways. Either we can increase the respiratory rate or increase the tidal volume. And these two are needed to get the carbon dioxide out. So we look into the determinants of mean airway pressure. So if you look at the mean airway pressure, if you increase the volume, so the tidal volume, as you see, the mean airway pressure improves, and then your oxygenation also would improve. Or the second way of improving mean airway pressure is increasing the inspiratory time. So if you increase the inspiratory time, you see the mean airway pressure increases, and that improves the oxygenation. So these are the modalities, or these are the variables that have influence on mean airway pressure. Volume is one, and inspiratory time is one. And inspiratory time is determined by the percentage of the flow cycle, because you have, in any flow cycle is fixed. You have an inspiratory time and an expiratory time. So if you increase the inspiratory time, your expiratory time comes down. If you decrease the inspiratory time, your expiratory time will have to be increased. So it is a percentage of the cycle time, and that is determined by inspiratory and expiratory ratio that we set, and the flow rates. So expiratory time is something that we cannot set, because you can only manipulate the inspiratory time. Or if you increase the inspiratory time, expiratory time comes down. If you reduce the inspiratory time, expiratory time goes up. So it is a dependent factor. And how do we, so by increasing the inspiratory time, what we achieve is improve in the oxygenation. But at the same time, by increasing inspiratory time, it can cause dyssynchrony. So we need patients to be more sedated to avoid this dyssynchrony. And there can be increased gas trapping, which we call as auto-PEEP. So these are some of the caveats or the disturbances that we can find, we would face when we increase the inspiratory time. Although it improves oxygenation, but there'll be significant dyssynchrony, and there can be auto-PEEP that can set in. So the mean airway pressure, I said it can be improved by increasing the volume, increasing the inspiratory time, and the third way that we can improve the mean airway pressure, which is an important aspect to improve the oxygenation, is by increasing the PEEP, because increasing the PEEP also increases the mean airway pressure. So one is increasing the volume, increasing the inspiratory time, and increase the PEEP. All these three improve the mean airway pressure and improve the oxygenation. And along with PEEP, PEEP will improve oxygenation by increasing the MAP, mean airway pressure, and reduces the shunt fraction, which others possibly cannot achieve. So that's in brief about the physics of ventilation. Now we'll move slowly to the flow dynamics. So when you look at the flow dynamics, so when we look into the scalars, so there is something called flow time. I'm sure most intensivists who are watching this would have seen these graphs on ventilators. So as you see, there is a flow on the y-axis and time in the x-axis. So one needs to appreciate the different components of this flow time. So here, this is the beginning of inspiration. And the tip here you see is the peak inspiratory flow rate. And this whole square one is inspiration. And the end of this is beginning of expiration. And this whole time taken for beginning of inspiration and the beginning of expiration is the inspiratory time, TI, what we call. And the bottom one, what you see is the expiration. As you see, inspiration is an active process, expiration is a passive process. And the whole time from beginning of inspiration until the end of expiration is the total cycle time. So these are the components of the inspiratory flow pattern. Then there's something called expiratory flow pattern. As you see, the expiratory flow pattern is what we described. And the time taken from the end of inspiration to the end of expiration is the expiratory time. So, and this is something that one needs to appreciate when you're looking at the ventilator to understand the inspiratory time and expiratory time. And and this whole expiratory phase, the initial part is the peak expiratory flow rate. And this is very important when we are assessing the flow time, because this will determine whether there is a resistance or bronchospasm that is possibly present, because your peak expiratory flow rate comes down when there is bronchospasm. I'll show in the next slide. So this is a flow time which you would see in bronchospasm. Suppose you have a patient with COPD or asthma, you see this peak expiratory flow rate is shorter and your expiratory time, so peak expiratory flow rate is shorter, and this expiratory time, which is a measure from the beginning of expiration to the end of expiration, is prolonged. So there is increase in the expiratory time. But after you give bronchodilator, so you would see there is improvement in the peak expiratory flow rate, which tells you basically there is a patient who is responding to the bronchodilation, and this response can be identified by looking into the flow time, where your peak expiratory flow rate becomes higher or longer, and your expiratory time comes down. So this is something that which you can appreciate in patients with bronchospasm in flow time. And the flow time is also advantageous in looking at the auto peep or air trapping. As you see, I'm sure most intensivists listening to this would know that when you put a end expiratory hold, so you can determine the auto peep. And auto peep, generally we prefer it to be less than 10, because if it exceeds more than 10, then there'll be dynamic hyperinflation and hemodynamic instability that sets in. And as you see, flow time helps you to ascertain the auto peep that may be setting in. As you see here, that expiration is not touching the baseline, and even before it touches the baseline, the inspiration would have initiated, and this is described as air trapping or auto peep. So why does this auto peep happen? So some of the reasons is because of higher tidal volume and higher respiratory rate. So and most importantly, shorter expiratory time or higher inspiratory time. So these are some of the reasons why auto peep sets in, because it is intuitive for you to understand you need a longer expiratory time for this to touch the baseline. So obviously, if you have shortened your expiratory time, then even before it touches the baseline, your inspiratory phase has begun. So shorter expiratory time is something that can precipitate this auto peep, especially in patient who is in active bronchospasm. And how do you treat this? Obviously, we have to treat this by reversing all this, by lowering the tidal volume, reducing the respiratory rate, and increasing the expiratory time. So the way we can, so if you see a patient with a flow time where your expiratory, your expiratory phase is not touching the baseline, then the modalities that you need to adopt is you have to lower the tidal volume if there is feasibility, lower the respiratory rate, and increase the expiratory time. So this is what I'm sure many of you would be doing in patients with COPD or bronchial asthma. So that is in flow time. So how will it look in flow volume loop? So in flow volume loop, I'm sure many of you, when you press the loop button in the ventilator, you would see an inspiration phase and then there is an expiratory phase. In the flow volume, this is the peak inspiratory flow rate and this is peak expiratory flow rate. So, what are the abnormalities that we can see? So if your expiratory limb is touching the baseline preemptively, so it suggests there is an air leak. So this is an important pathology that you can recognize in the flow volume loop. And auto PEEP also can be determined by the flow volume loop because it does not return to the baseline. As you see, this expiratory limb, it has to return to the baseline. So it is not returning to the baseline, which indicates there is an auto PEEP that is prevailing. And then there can be a scooped out pattern here. So this is the normal expiratory link. If you have something like scooped out, then you know there is increase in the airway resistance that is happening. Or you may see when there is a lot of airway secretions, you have this corrugated expiratory limb, which basically tells you there's a lot of airway secretions or accumulation of condensate. So basically what I've tried to show you is how the gas flow or the flow dynamics, flow time or flow volume can help you determine the various pathologies. So the various pathologies that we discussed is obviously your bronchospasm and auto PEEP, and then increased secretions, airway resistance, and air leaks. So these are the 5 pathologies that you can recognize in flow dynamics. So this is what one should appreciate when you're looking at the flow time or the flow volume loops. So now we will slowly move on to asynchronies. These are the different asynchronies that you can determine in the flow time. So we will go one by one. So there are around 5 asynchronies that we will discuss. So this is a delayed trigger. So where there is a, when I say delayed trigger, so you saw this is a patient's inspiratory effort, the one. So with this inspiratory effort, there should have been a trigger from the mechanical breath should have been provided by the ventilator. So there is a time lag. There is a lag time between the patient's inspiratory effort and the delivery of mechanical breath by the ventilator. So this is called delayed trigger. So one should understand when you see such a thing, there are certain causes. Obviously, the important cause is when you have a high threshold. So when the trigger thresholds are high, obviously there will be a delay in initiating that trigger, and that leads to this lag time between the patient's effort and the machine ability to deliver the mechanical breath. Or when there is auto PEEP. That's why we discuss so much about auto PEEP. If you have an auto PEEP, there is a lag time between the patient's inspiratory effort and the delivery of mechanical breath. Or when there is a weak inspiratory effort. So these are some of the reasons for delayed trigger. So then there is this ineffective effort. So ineffective effort, you have this patient putting an inspiratory effort here. Once the inspiratory effort, then there should have been delivery of the mechanical breath. And as you see, there is no delivery. There is a significant sort of a lag time, and there is no effective effort, breath that is triggered after this. So there is no delivery of mechanical breath despite the inspiratory. There, the initial one you saw the lag time, but here there is no delivery of the mechanical breath despite an inspiratory effort that may have happened, because your delivery of mechanical breath should have happened here. It has not happened because this dotted line you see is what you would have expected, and that mechanical breath delivery has not happened. And this we call as ineffective effort. Again, the reasons are similar as last time in a more pronounced way. So when the trigger thresholds are high, auto PEEP is there. Inspiratory effort is very weak, which is not sensed by the ventilator to trigger the mechanical breaths, or where there is higher tidal volume or higher inspiratory time. And as I said, why see this is very intuitive for audience. You don't have to memorize this. When I say there is auto PEEP, what is the reasons? You have short expiratory time, you have increased tidal volume, and then you have increased inspiratory time, isn't it? When there is an auto PEEP, so your understanding is expiratory time is, so to correct or rectify auto PEEP, you need to reduce tidal volume, and then you need to reduce expiratory rate, and then you need to increase the expiratory time. So that's why you have higher tidal volume and higher inspiratory time, which possibly leads to auto PEEP, and that leads to ineffective effort, or patient is profoundly sedated. So the inspiratory breath is not effective to trigger the mechanical breath. So this is the ineffective effort asynchrony. Then there's something called double trigger. So this is quite intuitive that with a single inspiratory effort, there are 2 breaths that are initiated as opposed to a single breath that you would have expected to initiate. This is double triggering that happens. And the reasons for double triggering is where patient is very tachypneic or high respiratory drive is there, and where you are provided increased pressure support, or there is high expiratory trigger thresholds. So expiratory trigger threshold is high and early cycling happens, or short time constant. So these are some of the reasons where double triggering happens. So increase. So where what it simply means, you are providing more support to the patient, more ventilatory support, which is helping them to double trigger. So which means you have to possibly you have to increase the trigger thresholds and reduce the ventilatory support to prevent this double triggering. Then the fourth asynchrony that we'll look at is auto triggering. So where here you see your inspiration has ended, but then there is continued inspiratory effort during expiratory phase, because this is an expiratory phase. This we call it as a bumpy sign. So where there is an inspiratory effort during the expiratory phase, where there is continued inspiratory effort, which we call bumpy. The cause is there is low pressure support and there is high expiratory trigger thresholds. So high expiratory trigger thresholds and short inspiratory time, because inspiratory time is short. So there is an additional sort of inspiratory effort during the expiratory phase and high inspiratory drive. So basically your inspiratory support is high and there is a short inspiratory time, which leads to this auto triggering, which we call as early cycling. So the fifth one is delayed cycling. So this is an early cycling. The opposite of this is delayed cycling. So in delayed cycling, there is a fast decline in the inspiratory flow, and there is a slow decrease in this flow decline. As you see, there is a sloping of these inspiratory phase. We call it as a slow decrease in the flow decline. And here the patient's inspiratory time is more than the inspiratory effort. The causes is again low expiratory trigger thresholds, and then is high tidal volume and high inspiratory time and low flow rate. So these are some of the causes for delayed cycling. Okay. So this is something which I would expect the audience to go through and keep these pictures in mind. So it makes it little more easy. So delayed cycling is opposite to your early cycling. So here I said low pressure support, and so it is a opposite of this early cycling. So that's about your asynchronous. So what we went through in the last maybe 5 to 8 minutes is various pathologies that are associated with flow dynamics, which can help you to identify various pathologies and the various asynchronies that are manifested. And asynchronous is where I would request the listeners to pay attention, because it's not easy. But now you are having this AI being incorporated, which I will talk about, which automatically identifies all these asynchronies and adopts the ventilation to reduce this asynchrony, which we'll talk about. So why is all this important? These are important because all this tweaking of tidal volume or tweaking of inspiratory time, tweaking of PEEP is done with an intent to recruit the alveoli, isn't it? So if you have any of these asynchronies that are present, or if you have any of these auto PEEP present, so they put a lot of stress and strain on the lung. Okay, and asynchrony is shown to produce lot of stress on the lung. So that is the importance. And this stress can also happen with increase in the ventilatory support. So as you saw, all the asynchronies can happen with low ventilatory support or high ventilatory support. So the whole essence is ventilatory support has to be optimal. So high also is not good, low also is not high, because both produce stress on the lung. And as we saw, increased sedation, analgesia, neuromuscular blockers, all these have a bearing on altering your trigger thresholds, because your inspiratory effort can be compromised and asynchrony can set in. So all this produces stress on the lung. By producing stress on the lung, it leads to lung injury, and this lung injury can be called as ventilator-induced lung injury. And because of overventilation and increase in this sedation, there can be disuse atrophy of the diaphragm, and diaphragmatic dysfunction sets in. And even the PEEP optimization is important, because excess PEEP or insufficient PEEP also leads to disuse atrophy and diaphragmatic dysfunction. And lung inflammation and systemic inflammation also leads to VILI. So, and even reduced. So here the upper row, you saw increase in the ventilation and increase in sedation, but the opposite, decrease in ventilation and reduced sedation. This also produces stress and strain, and that we call as patient self-induced lung injury, because patient becomes more tachypnic and there is reduced ventilation. This leads to self-induced lung injury, self-inflicted lung injury. So this slide, essentially what it is showing is over ventilation, over sedation, or under ventilation, under sedation, more PEEP or inadequate PEEP, all this has a bearing on lung injury or putting enormous stress on the lung, which can be willy or silly. And this can be compounded by ongoing lung inflammation. So that is what this slide shows. So don't get too overwhelmed with this. So what are the monitoring? Now we have understood this. So now the next question is, how do we monitor for mitigating these stresses? So the way we can do monitor is we have to look at various sort of a pressure indices that mediate injury. So the factors that determine the lung stress is dynamic transpulmonary driving pressure and peak transpulmonary pressure. So these are the two pressures which has a bearing on the lung stress. And there are certain variables which has a bearing on the respiratory effort, which is the airway driving pressure. So which is just the driving pressure, what we do in ARDS, which is P plat, plateau pressure minus PEEP. But this airway driving pressure is dependent on this transpulmonary driving pressure and chest wall driving pressure. So, and this chest wall driving pressure is dependent on your respiratory effort. So the changes in respiratory effort has a bearing on the chest wall driving pressure, and it has a driving on the your driving pressure. So it is important to now understand that your driving pressure is not only influenced by the underlying lung pathology or the ARDS, it is also influenced by your chest wall dynamics as well. Okay. And there's something called global respiratory muscle effort, which is a product of esophageal time constant. And there is electrical activity of diaphragm, which directly measures the stress on the diaphragm. And the normal values are meant to be 4 and 29 microvolts. So we will not dwell into the details, but what is important to know is all this flow dynamics, which we are using to optimize ventilation, has a bearing on lung stress and on your chest wall dynamics. And how do we monitor this? So we monitor this by a tool called, we look at the inspiratory effort, which we call as airway opening pressure for 0.1 second, where we look at the patient's inspiratory effort against the occluded ventilation. So you occlude the ventilation or occlude the airway for 0.1 second, and this will help to determine the patient's respiratory drive, whether respiratory drive is low or high, because you want an optimal respiratory drive. Very low produces stress on the lung. High airway respiratory drive also produces stress on the lung. And there are means to look at end expiratory occlusion, to look at the excessive respiratory muscle effort and the dynamic stress that may be there. And there is another component called delta P occlusion, which is a whole respiratory occlusion for the whole respiratory cycle. And this has a direct correlation to dynamic transpulmonary driving pressure, which we saw. But we looked into our ventilator. In our ventilator, what we are using in our unit, we have this measurement, which can be easily done, but we do not have delta P occlusion. Delta P occlusion is the change in the pressure swing when the airway is occluded for the whole respiratory cycle. 0.1 second is where respiratory cycle is occluded for 0.1 second to look at the change in the pressure, which will determine the respiratory drive. So this is what we have done in our unit, and the normal airway opening pressure or occlusive pressure, what we say 0.1, should be 1 to 4 centimeters water. So I'll just show you a video demonstration. So this is a GE ventilator. You can go to lung mechanics, and once you press, you can see, once you press the lung mechanics, you have this AWOP that comes, as you see, and you press that and it will show you. So here, this for this patient, the respiratory drive was 1, which was normal. So if it is less than 1, then you should be worried. Then you have to change the trigger to improve his inspiratory effort, because less than 1, it means there is a lot of stress on the lung. If it is more than 4 also, there is stress on the lung. That's what we look. So when the stress increases, your transpulmonary driving pressure goes up, and your driving pressure and transpulmonary pressure has a bearing on your lung injury. So this is our understanding. So you want an adequate respiratory drive. Low respiratory drive is dangerous. More respiratory drive is dangerous. So that is our understanding. So the simple way to showcase how all this has a bearing on your lung injury is, see, when you look at a pathological lung and your intent is to open up the alveoli, so all the problems happen in a spontaneously breathing during inspiration. So in inspiration, if you are giving a PEEP of 14 to open up the alveoli, this is just the numbers I put in dependent, and this is a dependent lung which was collapsed. So PEEP of 14 with pressure support of 8. So you have to calculate the airway pressure, which is the transpulmonary pressure is airway pressure minus pleural pressure. So if your airway pressure is 22 and pleural pressure is minus 4, your transpulmonary pressure is 26 in non-dependent. But in dependent, what happens? Your transpulmonary pressures became 30 because your pleural pressure was little higher. So 22 minus 8 is 30. So as you see, there is a differential pressure, and this 30 is too high, and this is recruited the alveoli. This collapsed alveoli is opened up, but with possible over distension. We do not want this. So how do we mitigate this process? So the way we mitigate is, because here you are, so what this example is showing is you are giving more pressure support, and this more pressure support is causing injury to the lung. So this is how we understand our whole flow dynamics. So here the way we mitigate is we have to reduce the pressure support. Suppose you, as you see here, transpulmonary pressure is 19 and transpulmonary pressure on the dependent lung became 22 as opposed to 30, where the only thing that you did was to tweak the pressure support. You reduce the pressure support to 3, and this was a state which is compatible with lung protection. So this is just a hypothetical example that I've shown you in an illustrative way to make you understand how pressure support is very important to ensure that we are not over ventilating the patient. Because you increase the pressure support, it increases the tidal volume, your transpulmonary pressure goes up, and that has a bearing on increasing the lung injury. So this is just a illustrative example. And as I said, our whole effort should be to resolve patient ventilator synchrony. So there are newer modes of ventilation like proportional assist ventilation, which is shown to reduce the asynchrony, and over assistance is prevented. So now the days will come where we really don't have to tweak and monitor for asynchrony physically, because AI has been incorporated into some of the ventilators. So AI is used to mitigate asynchrony, and the programming that is happens will in the ventilator will assess the patient's respiratory effort and look for the asynchrony. And there are studies done. So this was a study done in China where they looked at 5,899 breaths, and they found that 58% of the time the breaths were ineffective. So which means what we believe are adequate ventilation in our ICU patients, very often we may be creating a lot of asynchrony or dysynchrony between the patient and ventilator, and many of the breaths may be inadequate, and that produces enormous stress on the lung. And this is what was shown in the studies when AI was incorporated. And the AI algorithm showed that the sensitivity and specificity was up to 98% in determining ineffective breaths. And this was another study by Spain where they showed Blanche et al. There was a total divergence between the flow time and the pressure volume loops, and the deviation was more than 42%. There was no correlation, which means there was ongoing recurring dysynchrony that was happening. And here they looked at 1024 breaths, and they found there was more than 42% deviation or asynchrony that prevailed, and sensitivity was 91.5 and specificity was 91.7. And better care is the algorithm that has been incorporated into ventilator, which means AI is already being incorporated into ventilator to mitigate this asynchrony. And the better care is the name of that algorithm that is incorporated into one of the brands of the ventilator. And this was another study by Rem et al., where they have looked at ratio of exhaled tidal volume and inhaled tidal volume to ascertain the degrees of dynamic hyperinflation that may be prevailing. And AI was found to be effective with the sensitivity and specificity of more than 90%. So, which means to say, so to physically assess the dysynchronies that may be prevailing in our ICU patients with in different timelines is humanly not possible. So we need to understand the basics. That the basic understanding is we should not overventilate or underventilate. We should not provide unnecessarily higher tidal volumes, and we should not provide unnecessarily higher pressure support. We should not unnecessarily provide higher PEEP. On the same note, we should not underventilate also, and we should not provide suboptimal PEEP, and we should not reduce our pressure supports to a point that ventilation is becoming inadequate. And in essence, we should not oversedate or undersedate, because oversedation will have an impact on your trigger thresholds. Undersedation also will have an impact on trigger thresholds, and your impact on trigger thresholds will lead to all the dyssynchrony that will prevail in a patient. So this is in essence our understanding of this whole flow time. So the summary is your physical understanding is your airway pressure. This formula is something very important. Flow into resistance plus volume divided by compliance plus PEEP is something which you need to understand as a quintessence for ventilation. And the important determinants of ventilation is to improve oxygenation and reduce carbon dioxide. And this is achieved by tweaking these three variables: inspiratory time, your tidal volumes, and the PEEP optimization. And it is very important to understand all the various differential morphologies that prevail in flow time and in the flow volume curve and its correlation with various pathologies. And it is important to understand various asynchronies that are prevailing. And because the asynchrony or dyssynchrony is what will identify your inadequate ventilation. And as you see with the AI algorithms, it is shown that 50% of the time, some of the breaths that we believe are adequate, there may be elements of asynchrony and dyssynchrony that may be prevailing. And this is what AI has shown. And better care is the algorithms that are incorporated to improve these dyssynchronies that may be prevail. And what does all this have bearing? All this, if not appropriately done, puts enormous stress on the lung, and it increases your respiratory effort and your respiratory muscle effort, it increases. And together with lung stress and respiratory effort, your transpulmonary pressure goes up, and your transpulmonary driving pressure goes up, transpulmonary peak pressure goes up, and that can produce VILI, ventilator-induced lung injury. So it's under ventilation, it can produce silly self-inflicted lung injury. So this is our sort of a summarily understanding of this whole flow dynamics on ventilation strategies. So thank you one and all. So I'm sure it's very hard to assimilate all this in 20 minutes. So it is important that you read this and listen to this maybe few times, and imprint those dysynchrony sort of graphics in your mind, because this will be shown in exams, and one needs to have some understanding of the correlation of your trigger thresholds on the dysynchronies and your inspiratory time and expiratory time and expiratory late expiratory threshold triggers and so on and so forth on the dysynchronies. So thank you one and all.